The season 2 premiere ended on a huge cliffhanger, so let's see what's in store for episode 2.
How's our little girl who took a stair tumble?
I'm going to check for internal hemorrhage with an ultrasound.
What is your gut telling you?
Her gut?
Yeah, it's this thing that AI will never have.
I don't want to think about what my gut is saying right now.
Come find me when you know more.
Us, if you don't mind.
I don't mind us. Come find us when you know more. Do you want to jump on this trauma?
I've got my hands full. I don't want this one getting away from me.
We don't know what this is yet. Don't go jumping to conclusions.
I'm not jumping to anything. I'm just looking out for my patient.
It's very important to not get pigeonholed into a diagnosis as a provider, because sometimes certain signs and symptoms will make you believe that one of the topics you've read about most recently, something that you've always been curious about to see in real life, could be happening to one of your patients, so much so that you end up trying to force that diagnosis. In fact, there is a really clear example of this where med students, the second they study a specific rare condition, they believe they have it.
What do you got for us, Sam boy?
Alan Billings, pallet of roofing tiles fell 8 feet, hit his upper arm with an open dislocation.
Ouch.
2 rounds of fent, 1 then 0.5 per kilo, A&O with good vitals.
A&O means that he's alert and oriented. Good vitals means that he's not losing so much blood that he's becoming hypotensive, low blood pressure, as a result, not becoming incredibly tachycardic. Although, when someone is in pain and struggling like this, for them to be tachycardic is kind of normal.
Mr. Billings, I'm Dr. McKay.
And I'm Dr. Garcia from surgery.
And this is Dr. King.
Hi. Oh, it really hurts.
Imagine it really hurts while he's on fentanyl, so it's really bad.
It is an open dislocation.
Can you be more specific?
I think it's inferior, yeah?
Do you remember the name for that?
Sounds like a Harry Potter spell. Luxatio erecta.
That sounds like a Harry Potter spell, and I haven't heard of that in ages.
Sir, can you feel me touching you? Okay. Can you wiggle your fingers?
So they're checking for neurovascular compromise. They're making sure he has neuromuscular control of his distal extremity, meaning does it actually move? Are the nerve signals firing? Does he have sensation? When she's pressing on the wrist like that, what she's doing is performing basically an Allen's test, where you block off one of the 2 arteries, the main arteries that supply blood flow to the hand, and you see how quickly the coloration returns to the hand.
EFAS is negative.
Hey, what's next, Dr. McKay?
Ancef and gentamicin.
They're giving broad spectrum antibiotics here to cover gram-negative, gram-positive bacteria.
That sounds like a plan.
But with an open joint, he needs a washout in the OR with ortho.
Agreed.
Instead of wasting time down here, it should be easier to reduce under general anesthesia with fewer risks.
Possibly.
Let's get an opinion from ortho.
I actually agree with her. I think if you're going to already sedate him for surgery and all these procedures, you might as well do it for the reduction, meaning fixing the dislocation.
You're definitely new, Dr. Wishful Thinking.
Ortho like to take their sweet time. Okay, sedation orders, Dr. McKay.
100 of propofol titrate to effect.
Be back with that.
How's the day going, Doc?
Yeah, pretty good. Looks like your albumin's infusing. Oh, medical students Ogilvy and Juan are gonna be working with me.
Hello.
Student doctors.
You want them to try it? They gotta learn sometime.
Remember that mantra that we said in previous episodes, see one, do one, teach one, and this is a great opportunity to start teaching. However, I wish it wasn't an intern performing the procedure. You want someone with a little bit more experience. Usually in medical institutions, we have what are known as sign-offs, meaning that you've performed a specific number of these procedures under guidance. And once you have those sign-offs, you are technically trained enough to perform it on your own.
It's best if they watch the first one.
I can prep and drape.
Yeah?
And how about, if you're gonna prep and drape, close the drape behind you so the patient has some privacy.
After your albumins in.
That's correct. To prevent hypotension, we introduce albumin if we anticipate more than 5 liters.
Last time it was 6.
It's like a gallon and a half.
Yeah, and 1 liter of ascites ends up being about 2 pounds. So if they're pulling out 5 liters, you're pulling off 10 plus pounds of pressure off of the diaphragm, off of the intestines. So people that have stomach aches from the pressure, difficulty breathing, right away feel better. It's almost like a therapeutic drainage of the ascites. But remember, with ascites, you do have a high risk of having an infection, a spontaneous bacterial peritonitis. So you got to be super careful to make sure that you're sending off a sample to make sure that there aren't specific cell counts that are high, signaling the fact that there is an infection.
Make sure your entry point is safe by identifying the pocket of fluid.
That's not a pocket, that's a lake.
Yeah, but you do not want to hit a vein or artery on the way in, so make sure you check with color Doppler.
And it's great to do this under ultrasound guidance so that you have a lower risk of hitting an organ, an artery, etc. And the reason why ascites forms in a situation of a person who has cirrhosis, liver damage, long-standing, is because you start developing scarring within the liver. So you get back pressure into the portal vein. And when that back pressure forms, it actually pushes fluid outside of the blood vessel. And you start experiencing not enough fluid sensation by your body. So your body starts sending signal to certain organs and certain hormones, neuroendocrine system factors in order to keep fluid. So you start creating fluid retention. You already have this massive amount of fluid. So it can become quite problematic very quickly. And that's why when a patient who has liver damage, long-standing chronic liver disease, starts developing ascites, we see that as a significant deterioration of their liver. I've seen some statistics as high as 1 in 2 people end up losing their lives after 2 years once they do develop ascites. And obviously that doesn't hold true for every single patient, needs to be individualized, but broad population studies do show that pattern in some instances.
I can't see anything.
What happened there?
I can't open it, it's glued shut. I was trying to put on lashes. Oh my God.
If it's just the eyelash that's glued and not the actual eyelid, just cutting the lashes might be a solution here. Even if you get like super glue in your eye, I don't know if this is super glue, but what happens in an ER is mostly a lot of warm water, perhaps some sterile saline being sprayed into the area in order to loosen everything up. There are some really strong lubrication drops that we can put in or ointments that we can put in that can weaken the glue's hold. But if the glue gets into the eye, there's not much we can do other than after it's gone, make sure that there's no damage to the cornea, which we've actually seen as an example in the previous episode using the fluorescent stain.
So you glued your eyes shut with what exactly?
Super glue?
Super glue. I assume, actually I don't assume, is eyelash glue super glue?
Well, is it something you typically use to apply your lashes?
Good, look at that.
Typically something you use to glue shit. You break like coffee mugs and stuff. You know what I'm talking about. It's super glue.
Okay.
I had no idea, like genuinely. So him and I are on the same page.
Okay.
For a Z-track, we pull up the skin before advancing into the peritoneal space.
Oh, look, he does have oversight. This is great.
Fluid's clear.
Does that hurt as much as it looks?
Oh, it's not too bad.
Actually, it feels good for most patients, and fluid being clear decreases the likelihood of malignancy, decreases likelihood of infection, because if we did see infection, you'd see cloudy fluid coming out. If it was traumatic, perhaps it could be bloody, but that could also be a sign of malignancy. So it gives us some initial insight. You do have to send it for culture, though.
Hey, Ogilvy spiked the bottle for me.
What tests do we want on these fluids?
We want to know the white blood cell count, specifically the neutrophil count.
Cell count to rule out spontaneous bacterial peritonitis.
Good job!
What would make that diagnosis, Joy?
What's the number?
Absolute neutrophil count over 250.
Look at that gunner. See, I would fail in the moment. But then again, I haven't treated SVP in ages because I'm not in the ER. But I do know that you need to get to the ER quickly.
Oh, shit. I have a nun with conjunctivitis. Her swab is showing gram-negative intracellular diplococci.
Gonorrhea?
That does happen in nursing homes, but does it happen in the nunnery? Nunnery? It's a nunnery, right?
Sister Grace, under the microscope, we're seeing something called a gram-negative bacteria.
Is that serious?
It can be, if left untreated. But fortunately, we can give you a shot of antibiotics, irrigate your eye with a liter of saline, and give you drops to use at home every few hours.
How did I get it?
Patient privacy. Close the drape for such a sensitive discussion. I don't know why that's not highlighted.
It's gonorrhea. Traditionally, that's the sexually
I know what gonorrhea is, Dr. Javadi. I'm a nun, not a numbskull. I do a lot of work at an unhoused shelter.
Are you handling dirty sheets, pillowcases, soiled clothes?
Yes. Part of my day is spent doing laundry, making beds, disposing of old clothes.
Do you wear gloves?
When they're available.
Okay, well, let's get you your shot and set up for irrigating your eye.
I bet we can scrounge up a couple boxes of gloves while you're here. It's important to protect yourself.
Great advice. They're making a big deal of that saline flush. I mean, yes, but you could just wipe it. Like, I don't know how much extra that's going to do.
Okay.
Whenever I say for someone to flush a wound with saline, that's basically what I'm talking about. You don't need the fancy syringe, but that's a good way of doing it because it has a little bulb for protection so you don't get back spray.
1, 2, 3.
Humeral head is not reducing.
Should be done in the OR.
I am the OR.
Okay, we're gonna get this back in before ortho even answers the page. Mel, stick 4 fingers under that humeral head.
What he's asking her is to create a guide so it slides easier into the glenohumeral joint. It's good that he's already sedated with propofol because sometimes when you do a reduction on a patient who's awake, their tissues stiffen up so much from the pain that they're not able to relax enough in order to create the reduction successfully. But given the fact that he has propofol, they should be able to get this unless something else is blocking it or perhaps the angle at which it's dislocated is unique.
And when you feel the traction and lift it above the glenoid, that will convert this to an anterior dislocation and should pop right back in.
Also, they never really grabbed an x-ray, so they don't know if there's a fracture, if there's a bone chip there. Interesting series of events here.
1, 2, 3.
Very cool.
Sterile saline dressing.
Shoulder immobilizer and CT.
Guess you guys don't need me anymore.
Even though she had gloves on, I would still like to see her wash her hands after handling that much blood.
Well, my deposition is today.
Do you want to talk about it?
I'm not allowed to.
No, we don't have to talk about the deposition, but we can talk about how it is affecting you. Average emergency physician catches a med-mal case every 7 years. 9 times out of 10, the doctor wins. I've been sued 4 times myself. Dr. Al?
I've never been named in a lawsuit.
Of course.
All right, Mr. Digby. Dr. Mohan can cut your cast off now.
How long's the cast been on?
I don't know, but it's really getting itchy.
Okay, this cuts the cast, not the skin.
That's great to show that to a patient because that's an oscillating saw so that it will cut a cast that is very hard, but skin it will not. Oh, there's going to be an animal in there. I already feel it.
With the cast spreading.
Something is going to crawl out of it. Or he was hiding beef jerky in there. Something's going to happen.
Thank you.
You got to be careful. Those casts, once you cut them, can be quite sharp. So it's very easy to accidentally cut yourself, especially in one that is as dirty as this. So it obviously is rich in bacteria. And if you don't know if the patient has any wounds on their own, that could have been transferred to that surface.
Oh, I see you brought some friends.
Okay.
Oh my God, are those?
Maggots.
I'll need ethyl chloride spray to freeze them off.
Never saw that in nursing school, am I right?
We used to use maggots, by the way, to remove dead tissue. Maggots leave live tissue alone, but eat on the dead tissue. And why that's a good thing is that dead tissue can become infected. Live tissue has circulation, so it has white blood cells protecting it. So you want to get rid of dead tissue. Now we have more modern ways of doing this with creams, chemicals, even physical debridement. So like maggots are, in this day and age, are not always necessary.
More labs are back on our abandoned baby Jane Doe. Everything looks normal so far, but you seemed really concerned earlier.
She still needs a catheter urine.
Or not.
You can't trust a bagged urine.
Agreed, but we can avoid the trauma of a catheter.
With a suprapubic tap?
Oh, I may have a trick or two up my sleeve, Dr. Alashimi.
Does he have a way of stimulating the baby's reflex to urinate?
Is that water cold?
Right out the fridge.
Okay, Jesse, you can take the armpits. I'm gonna take the legs. 1, 2, 3, up. Dr. Alashima, you're gonna be our catcher. And Samira, you're gonna do suprapubic circles with that gauze. And the cold should stimulate voiding.
Even if she pees, it's likely to be contaminated.
Not according to the British Medical Journal. They did the research.
The research!
Nitrites and recaf.
She said that if there's any leaks or nitrates, those are signs of a potential infection. Not clear signs. You need more information. Leaks are just white blood cells. Nitrates are something that is present when specific types of bacteria exist, like E. coli as an example.
Next steps.
Foster care?
See, I would want to know what the baby's temperature is because the baby had a fever, and if the fever has resolved, that is a very good sign, especially without antipyretics.
There you are. Thought you forgot about me.
Oh, no, it's just with other patients.
You know, he's been in there for hours. They've dressed him. They bandaged him. They couldn't wipe the blood off of his knees and elbows.
What do you do for fun?
I mainly do what my sister likes. She loves Kennywood and the zoo.
No, what about you? What do you like to do?
I used to like the Renaissance Fair.
Really?
Yeah.
Isn't that kind of dorky, though, where everybody dresses up like somebody they're not?
Yeah, but that's the fun, you know? You can be anyone or anything you want. I actually had this alter ego that was a 17th century French woman's alter ego. Stop!
Oh! Another example of workplace violence against healthcare workers. She hit her head pretty bad there. Very easy to get a concussion, cervical muscle spasm in the paraspinal area.
You must be Dr. Alashimi.
And you must be Dr. Langdon. I've heard all about you. Welcome back. And this is?
Linda Stevens. 1 episode of substernal chest pressure resolved with rest. 12 lead negative for STEMI, heading for North 4.
So basically she was experiencing chest pain. They did an EKG that looked normal. But in a situation like this, you'd want to draw cardiac enzymes called troponins. And you do them serially to see if there is any growing damage due to a blockage. You have to monitor the patient clinically as well.
I have an app on my phone that can listen to our conversation and the details of my physical exam and write it all up in your medical record.
Wow.
Dorsalis pedis and posterior tibial pulses, 2+ and equal. Your exam is perfect, ma'am.
Oh, that is good to hear.
I will be back when your blood tests are ready. Let us know if the chest pain returns.
Thank you.
You are so welcome. What do you think?
Well, I don't think it's cardiac.
I mean, what do you think of the app?
I mean, it's hard to say without seeing the full thing.
Take a look.
Oh my God. Do you know how much time this will save?
Studies show you can spend 80% less time charting.
So I would love to spend less time charting. A lot of these apps are currently in beta and are imperfect. You have to be really careful with the utilization of these apps prematurely. As long as they're well tested, they're validated, and there is human oversight. That is the one thing we're missing in this whole AI thing where people think AI is taking over. It's a must to have experienced human oversight. But there's also the troubling portion of AI where our younger trainees are becoming so reliant on AI that they are actually not learning how to oversee the AI. So part of what should be the norm in education should not be shunning the use of AI. It's teaching the responsible use of AI to learn how to oversee the program and make sure it's doing its job correctly.
Excuse me, it says here she takes Risperdal, an antipsychotic. She takes Restoril when needed for sleep. So is that,
AI. Almost intelligent.
That's a good one.
AI is 98% accurate at present. You must always carefully proofread and correct the minor errors. It's excellent, but not perfect.
This is amazing. Checkup.
What is happening?
You speak Farsi?
Oh, I did my undergrad at UCLA. A lot of my friends are Persian.
So you learned the language?
Enough to break the ice.
I am impressed.
Me too. That you had friends.
Gunners are notoriously disliked by their fellow students and comrades.
How's our shoulder guy?
Oh, he slept like a baby. CT angio shows no vascular injury.
So a CT angio is basically a CAT scan, but they put into an IV contrast that allows you to see the blood vessels very clearly. And when you do that, you could see if there is damage because that contrast would be leaking in an area. Also, like a CT angio would be used in someone's coronary system to see if they have a cardiac artery obstruction. So there's multiple uses, obviously.
This is Noelle. She's our
Bed control manager. No, we met.
Case manager, and this guy will be staying,
Oh, he needs surgery.
which his insurance will pay for at Westbridge Memorial, not here.
Wait, so we have to transfer?
If he's stable.
I believe it is. Look on the bright side. We're going to free up a bed and discharge a patient.
I mean, that's great for us, not so good for him.
Yeah, this happens absolutely in the world that is our healthcare system. A gentleman who was healthy, school teacher, good insurance, had a heart attack, was taken to a hospital that was out of network, completely out of his control because it was an emergency, and as a result was charged this huge sum of money where it nearly made him bankrupt. But because he got press on his side and it put all this pressure on the hospital that was practicing with predatory billing practices, they were able to get his costs down like 99.9% to something very reasonable.
You still planning on leaving tonight?
Yep.
I don't understand why you can't leave in the morning.
Is there a little romance happening? Are they bringing a little Grey's Anatomy, a little ER into the pit?
I'm fine.
That's good. Follow my finger. How's the head?
It's a little sore.
Lean forward. Let me take a look. Yeah, you're gonna have a pretty good goose egg.
I love their exams. Oh yeah, yeah. That feels like kind of something. Do you want to look? What if there's an opening there?
Headache?
No.
I can get you some Tylenol unless you need something stronger.
All right, so this is a great example of how to diagnose a concussion. You just watched it. Patient has symptoms of a concussion, experienced a head injury, concussion. A lot of people think they need to get imaging in order to diagnose a concussion. Imaging actually doesn't show us anything for a concussion. Imaging is important when a head injury is severe enough to potentially cause bleeding, or if there are neurologic findings that are concerning, yes. But the concussion is a concussion.
So I'm really sorry about all that. The guy robbed the liquor store last night. He tried to get away on a bicycle, but wiped out and took off on foot. He must have hobbled in here more so to hide out than to get stitched up, I think.
You catch him?
We will. Anything you could tell us about him will help.
You think he gave legit information?
Probably not, but it's all we have at the moment. If we do find him, you may have to testify in court, Dr. King.
In court?
As a material witness. Attest to his injuries, his treatments, simple stuff.
Yeah, but we'll cross that bridge when we come to it, right?
Yeah, I was gonna say, they're jumping ahead quite a bit here. How about the fact that she might want to press charges? They're completely glossing over the fact that there was an assault that happened.
Okay, Kylie, we need to take some blood now.
You had to do that?
Yeah, but I promise it'll go super fast and only hurt for like a moment, okay? So.
Oh, I see the sign! I see the sign! I see the sign! Is that a little hypermobility there? Showing a sign of EDS? I'm seeing a little foreshadowing happening right now.
Super baby's urine dipped negative, 0 WBCs, respiratory panels positive for rhinovirus.
Great! Well, I mean, not great that the baby has rhinovirus, but it just means it's an upper respiratory infection that will pass.
Nice and clear. With an infection, it'd be kind of cloudy. Joy, get ready to spike the third bottle here after I clamp.
All good in here?
Yes. Dr. Whitaker was just explaining that with SBP, we would see a turbid appearance.
Why is he quote unquote using what I said earlier in this episode?
However, he failed to mention that bloody fluid indicates either a traumatic tap or the likelihood of hepatocellular carcinoma, in which case we would send for cytology.
That is correct.
Kid knows his shit.
He's so smart. Okay.
Hey.
How's it feel to officially be a doctor?
It's pretty cool, actually. I get my first paycheck today.
I wonder when they started, because usually July is their first start date, and it's July 4th. I wonder how it's his first paycheck.
Ogilvy is really smart and likes to show people.
He's obnoxious.
Well, what he is your competition. He's a gunner.
Yeah, right. He's not my competition.
He's from out of state for a 4-week sub-internship. You don't think he's angling for an emergency residency spot here next year?
When we do our rotations, we do rotations called sub-internships, sub-Is, where essentially we're trying to show off our clinical and interpersonal abilities to the people that make selections for the residency program. So he clearly wants a spot.
Orlando Diaz.
What's the story? He tripped over some rebar. Tryptophan. I don't know. Orlando, open your eyes. Hit his head?
I guess.
Why didn't you call 911?
He wouldn't let me. He was talking, not so much now.
Orlando.
Check a pulse!
Jesus. He drunk? No, ketones on his breath. He diabetic?
I don't know.
Wow. Okay, so I don't know if it's ketones on his breath. Ketosis, he smells acetone. A lot of people think when someone is in DKA, the reason that their breath smells fruity is because of sugar. It's actually because of acetone.
Altered head trauma, possible DKA. Call it overhead.
So DKA is an emergency. I would have liked to see him check for a pulse because in DKA, you start actually not just having out of control really high sugars, but also acidosis in the blood and ketosis in the blood to a degree that is very dangerous because of fluid depletion and electrolyte shifts. And these electrolyte shifts can include potassium, which can move the potassium either into the cell or out of the cell, depending on what's happening in the process and in the treatment, which can cause someone's heart to stop, go into a lethal arrhythmia, all sorts of issues. So usually people who are going into DKA need ICU management.
That's definitely ketones. We need to do an AccuCheck.
I'm on it. He's tacky at 124, pulse ox 97, BP's 106/72.
So again, in this situation, you're trying to stabilize the patient by giving fluids, insulin, and some people think that you're just trying to give insulin in order to drop the blood sugar. That's certainly part of it, but you're also trying to get some of the potassium back inside the cell. Sometimes the potassium is incredibly high, so you think you don't need any potassium, but actually that's because the potassium has shifted from the cell into the bloodstream. So a lot of things can go wrong in a scenario like this, kidney damage, etc. You even see people breathing in a very specific type of way in order to blow off more carbon dioxide to lower the acidic load on the body.
Good bowel sounds. Abdomen is soft, non-tender.
And you also want to check the patient to figure out why they went into DKA. Some patients go into DKA because they didn't take their insulin or they forgot it, what have you. But also some people go into DKA because of sepsis, an infection, post-surgery, etc.
How do you know it's non-tender?
Because I didn't see any grimacing.
He's altered. He didn't even flinch for the IV start.
I meant to say non-rigid.
Huh.
Yeah, med students shouldn't be correcting other med students. I would jump in there right away as a preceptor.
EFAS negative. How can I assist?
You can check in with Dr. McKay or Dr. Santos.
If you don't mind, I'd like to observe, learn how you handle things.
Whoa, blood sugar's critical high, it's over 500.
Ding, 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 ding.
Sounds like diabetic ketoacidosis. We need to start treating that, then right to CT to rule out an intracranial bleed.
And the reason why they're doing imaging of the brain is because he had probably this episode of DKA and fell and then hit his head. In a scenario like that where a patient is unconscious, you need to figure out if he's bleeding internally.
This guy needs an insulin drip, right? 0.1 units per kilo?
No, not without knowing his potassium. Insulin causes an intracellular shift, and if the potassium is under 3.5, the drip would kill him.
That is very true.
We can start with lactated ringers, 1 liter per hour until we get the results from the Chem7 and the VBG.
And what's interesting is sometimes we have to manage the electrolytes in such a way and the ketones in such a way where we're continuously giving insulin, even though the sugar is normal or starting to become low, where we actually give someone sugar and insulin at the same time. Pretty unique.
Why is he in DKA?
Maybe he's not taking enough insulin.
More frequently, a precipitating event can be identified, such as pneumonia, urinary tract infection, stroke, myocardial infarction, pancreatitis.
Yeah, we always check for those. They're part of the standard order set, right?
Why are they so angry?
Glucose 521, sodium 129, potassium's 3.7, chlorides 97, bicarbs 8.
So hyponatremic, hyperglycemic. Yeah, they're looking for a metabolic acidosis, anion gap.
We can start the insulin drip and add 20 of K to each liter.
Big anion gap of 24. It should be under 10. We follow it to assess progress.
Actually, the 2024 international guidelines state that anion gap should not be used as they can be misleading in the presence of hyperchloremic metabolic acidosis. I recently had a case in the ICU.
That's a good way of presenting it. And I actually like doing that, especially if I recently read something, because it's so easy to get points and credit when you're in a clinical setting because you happen to have had a patient recently with it or just did some extra reading on the subject. But if you state like, this is the reason why I know it, it instantly feels less arrogant or douchey to flex your knowledge.
Insulin drip, fluids with KCl, capillary glucose every hour, Chem 7 every 4 hours.
ICU's gonna want a double lumen midline too.
I can do it.
7.5 glove.
7.5 glove is the size. Interesting, because I use a 7.5 glove. Impressive that we all share a 7.5 glove size.
Can I just say we evaluate our students not only on their fund of knowledge and on their procedural mastery, but also, maybe more importantly, on their skills as team players.
Interpersonal skills are very valuable. I would actually pull them apart and discuss that with them one-on-one.
This is Mr. Randall. He's been erect for the last 8 hours.
Should have gone down by now, right? It happens. It's a good thing you came in, Mr. Randall. I'll take him right back.
Erections lasting that long definitely need to be evaluated by a physician, usually in an ER setting. Frequently, where most people have had interactions with this is on commercials for medications like Viagra or Cialis. They always say,
get medical help right away for an erection lasting more than 4 hours.
And what's interesting is with those specific medications, the risk of that happening is really low. Like, I think in the research, when they actually tested these medications against placebo, there was almost no increased risk of it happening. There are certain medications that are used for erections that are injectable, and with those medications, it can happen.
Mr. Randall. Ian, did you take anything that might have led to this condition?
I used an ED injection, 2 actually. I gave myself a second shot, 1 on each side.
There's also some medications that have nothing to do with erections that can cause this to happen, and that's why you need to do a very thorough med check on these patients to make sure. I remember on a medical board's questions, trazodone, antidepressant, is implicated in this.
Double the recommended dosage?
It's our wedding anniversary.
Is this a big one? The anniversary, is it important?
Gotta watch your adjectives.
Yeah, like a milestone or?
It's our 20th.
Oh, nice.
Normally what happens during an erection, you have a very careful balance of the nervous system. So in medical school, we teach something called the P&S, point and shoot. I think you can guess what those stand for. And the reason why I like to say point and shoot, P&S, is because P stands for parasympathetic nervous system and S stands for sympathetic nervous system. So you need to activate those in order to start both of those processes. And having a healthy balance between the two is necessary for proper function. When your body is starting the process to point, you actually get an influx of blood flow that ends up putting pressure on the venules that allow drainage of the area, essentially keeping them shut. And when that happens, you start getting an erection. But in certain scenarios, those venules become so blocked because of excess pressure that they don't let off, where you actually need to go in and drain it. Yes, you are actually going in to the corpus cavernosum and draining it. The reason you drain it is because if it stays there too long, that blood becomes deoxygenated, there becomes damage to the endothelial lining of the area, so you can actually develop permanent ED, obviously in extreme cases, by damaging that tissue.
How are we doing?
He's out from Versed, did a lidocaine block to the dorsal penile nerves at 10 and 2.
Yeah, he's ready.
Wow, full!
Enter the dorsal side to hit the corpus cavernosum.
You want to be careful so you don't hit the urethra, where the urinary stream comes from, nerves, specific arteries, veins, etc.
Barry Mitchell, eating breakfast at Pamela's, sudden onset respiratory distress, some stridor, decent pulse ox but trouble speaking.
Some stridor, I'm worried about choking.
And they tried the Heimlich?
3 times.
Any history of asthma? Sit up for intubation.
Agreed. Okay, sir, scoot across.
Always a good sign when they slide over on their own.
Came from a diner with an upper airway obstruction. Didn't clear with abdominal thrusts. We gotta take a look.
Heart rate's 118, pulse ox 96.
Mr. Mitchell, we're gonna sedate you to look down your throat, okay?
Draw ketamine and rocuronium.
What about ketamine only?
No, we need full paralysis for a successful first pass intubation.
Might not need an intubation if it's just a foreign body.
We can't assume that. It could be subglottic stenosis, epiglottitis.
Oh, all of those things happening that acutely would be very, very unique. Quite low on the differential.
Ketamine only, 80 milligrams.
In that case, I'll leave this in your capable hands.
This is the beauty that is healthcare. 2 reasonable physicians can look at the same patient and have 2 different approaches for different reasons. In most instances, the way it should be decided is based on what the patient wants. In an ER setting, because of the tense nature, because patients are usually not able to advocate for themselves, at least properly, because of the acuity of the situation, the senior physician should take charge.
Okay, let's lay him down, take a look.
Okay. Good view of the epiglottis.
Gotta be careful to not break teeth.
And mystery solved.
God, it's so cool that they have these video scopes now.
Get a good grip on it.
Okay. I can see why the Heimlich didn't work.
Rotate a little bit.
Gotta be careful, because you pull too hard, you can cause bleeding.
Voila! That is why you give ketamine alone. Because if we gave a paralytic, we would have to intubate and ventilate for an hour.
What do you got? Combative college kid. Flipped down the library, tased in the neck by campus security. 5 midazolam, didn't touch him. Would you get the coffee 2901?
Substance use of some kind.
Let me out! Let me out! Let me out!
He's definitely going to develop some muscular damage fighting against the restraints like that. You definitely need to sedate him. People used to lick each other's eyeballs? You got to click here for that story. There's a lot in here, and as always, stay happy and healthy.